Hello, and welcome to AFD TV. Here we have Dr. Sam with Dr. Rupert, and we're going to talk about chronic pain disorders.
Thank you, Sithara. Welcome, Dr. Rupert.
Well, thank you, Dr. Sam.
So, treatment of chronic pain disorders. So what are some of the disorders that you most commonly treat?
Well, the most common disorders that we treat for chronic pain usually end up being chronic headaches, chronic neck pain, and chronic back pain.
So we do have our little patient here, demo here. And so say if John is having chronic headache, what kind of work would you offer for him that's beyond medical therapy?
Okay, well, that's a great question. And we get to see a lot of patients who have failed more conservative therapy or more traditional medical therapy. We always recommend patients do the conservative stuff first, but by the time people come to see us, oftentimes they're at their wits' end, and we're looking for a solution to a problem rather than a bandage for symptoms. When we see those patients, we oftentimes go through a workup of what's called an interventional workup, which is an identification or a diagnosis of pain generators. What anatomically is causing the problem? As an example, if you fell and you heard a snap in your arm and it hurt, you might think it was broke. You'd go get an x-ray, and if it was broken, everything at that point seems to make sense, and we go down that pathway of repairing that fracture, healing from that injury, and going on. Well, a lot of times, headaches as an example, patients may go through years and years of repeated imaging studies which don't show a definitive diagnosis. We try to look at the pathways of pain and use the responses that patients have to identify how and why they're hurting.
And the good news, if we can find the source of the pain, then ideally we can reduce the amount of pain medicines out there and narcotics.
Exactly. So the premise to solving any problem is to understanding the problem. And if we can understand what the problem is, we can develop a solution or treatment plan to treat that. If somebody has a problem that is in their cervical spine that's making them hurt in the front of their head, we can do a lot of things to treat the front of their head, but they may never get better. So we try to identify what it is that's specifically making them hurt.
So you have some implants with you here in your pocket that you can show us?
I do. I think I may have passed them off. Oh, I'm sorry, I do have them.
Okay, very good.
So once we identify a pathway, if a nerve block used as a diagnostic tool doesn't itself provide some long-standing durable relief, then we look oftentimes to either lesions to those nerves to ablate those, freeze them, or use chemical neurolytics to block that pathway for a good duration of time. More recently, in the past 7 to 10 years, we've been doing a lot of implantable devices because the success long-term over the destructive lesions is greater.
Well, I know you guys must be doing something right, and you have patients who are flying from different states.
Yeah, we've had patients coming in from California, Michigan, North Carolina, South Carolina, Ohio, Michigan.
For the hope of getting better. So,
Correct.
So, for example, John, he's having chronic headaches, and you identify the lesion more in the cervical area. How would this implant work?
Well, if we can identify the pathways, what we'll oftentimes do is we'll place one of these electrodes over top of the nervous system. Sometimes that goes at the level of the spinal cord. Sometimes it goes at the level of the peripheral nerve. It oftentimes depends exactly on where we find the problem. For headaches, as an example, we have found a lot of success by placing electrodes actually over the patient's forehead or brow, as well as the upper cervical spine. We can use those two in combination to treat the entirety of the spine.
And how does the actual device look like in your hand?
Well, this is the stimulating part of the electrode, and then this is the working part of the electrode, which is just a battery. It's an implantable battery. It's basically a pacemaker battery, which people are more familiar with, but a pacemaker battery or a neurostimulator battery lasts about 10 years, very hypoallergenic, placed underneath the skin about 1 centimeter, rechargeable, just like our cell phones.
How do you recharge it?
You use what's called induction, which if you've ever flown on an airplane and seen the little pads that they advertise where you throw your cell phone on it,
Sure.
it charges your cell phone. It works the same way.
So where would you implant the battery approximately, usually?
Usually batteries we put over a patient's hip on their dominant hand side.
Okay. And then how would they recharge it? They put a pad on there?
They either tuck in the belt line, they'll tuck in a little charging unit over the top of the skin. If they're sitting down to eat dinner, they can sit and they can put it in. If they're spending a half an hour watching a TV show, they can charge it every day, make sure that the device is charged, not unlike our current cell phones.
Nice. And so even with charging after about 10 years, time to change the battery?
We think.
Okay.
The fortunate thing is that the rechargeable technology hasn't quite been around for 10 years. We've done very few replacements so far.
Got it. Yeah. And who makes this device?
This device is made by St. Jude Medical, although there are several device makers, 3 big ones, and then several small ones that are available in Europe, but not yet in the United States.
Got it. And is this done as an office procedure?
No. Well, trial placements are done as an in-office procedure. It requires a very sterile operating condition, but not so much as being a hospital or a surgical center. When we go to do a full-on surgery, if a test situation works and helps, we go and put the battery and everything else under the skin. That's done in a hospital or a surgery center.
And you operate at Williamson Medical Center?
Yes.
Yes. And so what's your training and background?
Well, my training is, I took a fairly circuitous pathway, but I originally was an engineer and worked for Johnson & Johnson creating staple devices for surgeries, and went from there into doing orthopedic research, decided to go to medical school, and then went into general surgery, and from general surgery started doing anesthesia. Didn't exactly like it, but found that interventional pain as an extension of anesthesia used my surgical skills well, and from then on I've done a couple additional fellowships and extra boardings to be able to provide these services.
Oh, that's wonderful. So do you do the standard epidural injections and all that as well?
Yeah, sometimes we get lost in the more difficult patients. We love to see the difficult patients, but we also like to see the patients who have acute pain. I'm just as happy to guide somebody through physical therapy and not doing any interventions at all, and really assessing their problem for what it is, trying to get people back. What we really look at is preventative medicine, just like you guys do from the primary care side of things. The healthier we can make patients, the better we can teach them, the better it can roll onto their family members and their spouses and their young ones.
But your love is more the interventional procedures using the electrodes to help when patients went to other doctors, lost hope, can't find their source.
Absolutely, absolutely. I think that's been my calling, and we've been able to just treat these patients, come up with a solution. Yeah,
there's plenty of them out there. So yeah, and it's nice that there are places where they can find some hope. And again, get off the scourge of narcotics and opiates. So if you had to list the 5 most common conditions you treat.
The 5 most common conditions are now working up of headaches, neck pain, back pain, and then some complex neuropathic disorders, even peripheral neuropathies, or something called complex regional pain syndrome.
Fibromyalgia?
Fibromyalgia is something that we use a lot of integrative work with those patients. We try to guide them through physical therapy, psychological counseling, things that really put them onto a habit of coping with a chronic disease that we don't necessarily have a solution for.
Got it. Well, we could talk about this forever. I mean, I'm glad you're here. So Vertex Pain in Franklin near Williamson Medical Center. So that's great. So thank you for joining us on AFD TV.
Well, thank you very much. I appreciate the opportunity to be here.
The medical advice provided in this video is informational and strictly the opinions of Dr. Sam Mudralla and AFD Clinics. For a personalized medical opinion, please consult your primary care physician or visit one of America's family doctors' clinics today.